Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Pinaki Roy, gastroenterologist at Spendan Hospital, Kolkata, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hi, myself Dr. Pinaki Roy. I am MD DM Gastroenterology, currently attached in NRS Medical College in the Department of Medical Gastroenterology.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
Actually, IBS is irritable bowel syndrome. It is in a simple way, it is a disease of digestive system, and it is a syndrome. It consists of multiple symptoms, and it is a symptom complex. And it usually presents with some kind of pain abdomen or some kind of change in stool frequency in the form of altered bowel frequency or bowel consistency. Okay, so pain abdomen related to defecation.
Why do you think IBS remains one of the most underdiagnosed gut conditions in India?
What happens, this IBS, that is irritable bowel syndrome, is most of the cases are undiagnosed or underdiagnosed, because most of the patients usually not come to us. Most of the patients usually go to for some herbal or Unani medication like that, and sometimes patient even considering that it is not a symptom of some GI problem, it may be some psychological issue. For that reason, they used to prefer some local or home medication, and usually most of the time they don't come to us. But when symptom becomes severe and gradually patient become frustrated and all those things, then patient usually visit to us. For that reason, usually the studies which have assessed the prevalence of IBS is mostly biased and mostly underreported.
What are the top 3 red flags that make you suspect IBS in a patient?
Actually, the question is little bit tricky, because usually when we diagnose IBS, we usually use red flag sign to exclude IBS. Because those patients who have red flag sign in the form of blood in stool or severe pain abdomen or lump in the abdomen or weight loss, these kind of symptoms usually called red flag sign, and those patients who have these red flag sign, usually we exclude the diagnosis of IBS. But if you say the most important points to diagnose IBS, that will be, one is pain abdomen, it is related to bowel movement, and it is related with the change in bowel consistency or form or frequency of bowel movement.
How important is the patient's history compared to investigations in IBS diagnosis?
For diagnosis of IBS, history is the utmost important thing, because IBS is diagnosed only by history. No need for any investigation to diagnose IBS, because the IBS diagnostic criteria according to Rome 4 and previously Rome 3, Rome 2 and all those criteria, all the criteria was based upon the patient symptoms. Okay, so there is very around about 5 to 10% role of investigation, any investigation to diagnose IBS, and that is mostly when the diagnosis is in dilemma, and to exclude IBS we do some investigation. Otherwise, 95% of patients there is no need for any investigation, only history, and history. That is the most important thing.
How often do you see IBS overlapping with anxiety or depression, and how do you address it?
It's a good question. Actually, IBS patient, round about 1/3 of IBS patients have some kind of anxiety-related problem, and it has been found in the studies that 1/4 of patients are suffering from some amount of depression related to this IBS. Okay, so it is very common and it is closely related with IBS. And it happens because it is a chronic disease, and that is also cause little bit of frustration to the patient, as well as the pathology and pathogenesis of IBS, as well as the psychological problems in the form of anxiety and depression is interrelated. Okay, for that reason, it is very commonly found in patients with IBS. How to address it? I will say regarding the answer of this question. It will depends upon the pattern of patient presentation. We usually use some psychotropic drugs like tricyclic antidepressants or SSRI in a very low dose. that is very low dose, which usually not commonly used by psychiatrists. We usually use a very low dose, and before using any drug, and the first and foremost thing is the assurance. If we can assure the patient that it is not a very serious disease, not about to worry, it is not a life-threatening disease, then around about 30 to 40% of anxiety and depression mostly related to this anxiety related to IBS. And the rest of the part we need to advise some kind of drugs like some psychotropic drugs in a lower dose like tricyclic antidepressants, SSRI, SNRI, mirtazapine, like that.
Once IBS is diagnosed, what is your first-line approach to management?
It is my first line approach. It is also the guideline says all the first line approach will be same, and that is the first thing will be the assurance. If you are confident that you are dealing with a case of IBS, you assure the patient that it is not a life-threatening disease. It is usually self-limited. It can be controlled with little bit of medication and change of some dietary habits. Okay, and if in the change of dietary habits and as well as assurance, it is not sufficient, then we start some drugs. And there are multiple drugs are there to control the symptoms of IBS, like in the form of reducing the frequency or increasing the bowel movement or relieving the pain abdomen, like that. But the first and foremost thing is the assurance. And there is change in dietary habits, like ask the patient to follow low FODMAP diet for a certain duration or avoid any wheat or any milk or dairy product, like that.
What's your opinion on the role of rifaximin in IBSD? Where does it fit best?
Regarding role of rifaximin in IBSD, before I come to this topic, because IBS is one is IBSD, that is diarrhea predominant, one is IBSC, that is constipation predominant, another is the IBSM, that is mixed pattern, and IBSU, that is unclassified. Out of that, the rifaximin is a significant role in treating IBSD patients, and the multiple studies have shown that rifaximin in a 550 milligram thrice a day for 14 days, it gives a good amount of patient, gives a symptomatic relief in the form of relieving pain abdomen as well as relieving the stool frequency. And usually the response sustains for around about 10 weeks. And after that, there may be some percentage of patient may recur, and there may need for some repeat dose of rifaximin. So, and that is occurs due to this pathology, the baseline pathology of IBS and IBSD mostly. It is a dysfunction of this gut-brain axis and the dysbiosis, that is a change in microbiota within the gut. Okay, so rifaximin is a luminal antibiotic. It usually not absorbed in the system, and this luminal antibiotic usually helps to cure the normal flora of our gut, and in this way it helps to relieve IBS symptoms. So usually the rifaximin fit most in the IBSD variant, and guidelines recommend that also. Even in IBSC, it has been shown that the patients of IBSC, some patients have some methanogenic bacteria in the gut, and due to this production of increased amount of methane, that is reduced gut motility, and that leads to constipation. In those patients also, even in constipation predominant patients also, the rifaximin may be helpful by changing the microbiota.
How important is patient counseling in IBS management? What key messages do you give?
Regarding counseling, it is the most important thing, because when patients comes to us with a huge expectation and background, some anxiety and frustrations are there, they think that possibly again there will be no hope because they have visited so many doctors. And once you counsel the patient that this is not a life-threatening disease, it will not lead to your death or like that. It will just hamper your quality of life. So first thing, you know that why the disease is occurring and how to be good. Don't try to cure IBS. It will be with you, but it will not cause any harm or it will not cause any problem to you. So don't be worried with this disease. Okay, so counseling in the form of assurance is the most important. And another thing is a regular physical exercise, regarding lifestyle changes in the form of regular physical exercise, in the form of more consumption of water. Those patients who are constipation predominant, more consumption of fibers. Those patients who are diarrhea predominant, we ask to reduce the amount of fiber in the diet, as well as avoid lactose containing drugs. So change in dietary habits. These kind of things we should suggest. So for that reason, counseling is most important. And the key message is, again, I say that assurance is the most important thing, that it is not a very serious or life-threatening disease.
What's the most memorable IBS case you've handled, and what did it teach you?
I'll give example of one day, that is multiple patients are there because What happens, those patients who first time visits to us after visiting so many physicians and general physicians, all those things, and this patient, one patient came to me and she said that she is suffering from pain abdomen and there is increased bowel movement, diarrhea. They are saying that she used to go to the toilet around about 5 to 6 times a day, and each time she had a pain abdomen, and usually it is little bit of passing stool. But when we used all the sites, she has been diagnosed as IBS-D. But what happens when we people usually we used to do, we ask the patient to check the Bristol stool scale. There is one stool scale is there, and that will guide us that whether this patient is suffering from IBS constipation predominant or diarrhea predominant or mixed pattern. So, but what happens usually due to lack of practice of using these Bristol stool scales, most of the physicians and even gastroenterologists also usually not very used to use the Bristol stool scale. And for that reason, they only consider the frequency of stool is the important factor to diagnose the type or the subtype the IBS. For that reason, that patient was diagnosed as IBS diarrhea predominant. But when we ask the patient that you see the Bristol stool scale and tell me what is the pattern of stool you usually used to pass, and what she saw that she used to pass around our Bristol 1 or 2 type of stool. And for that reason, she feels incomplete evacuation, and for that reason, she used to go multiple times toilets. So the diagnosis totally changed. So that patient was diagnosed as IBS diarrhea, and multiple times physicians are using some kind of antidiarrheal drugs, and ultimately that precipitates his symptom, and patient become more and more constipated, and the symptoms aggravate. So when I see that patient is suffering from IBS constipation, so total the spectrum has been changed. So I stopped the antidiarrheal drugs and I start some laxatives. There are multiple laxatives are there with us nowadays, and the patient got relief with these symptoms. Significant improvement was there. So my message from this case was that when you are dealing with a case of IBS, you try to include following this Bristol stool scale in your practice, because it will take around about 30 seconds or not more than that, and ask the patient that what kind of stool you used to pass. It is not you will suggest that it is I am suffering from diarrhea or I am suffering from constipation. The physician will suggest, a physician will diagnose that whether you are constipation predominant or diarrhea predominant, but not go to with the frequency. You check it, and what the Bristol stool scale says, whether stool pattern is 1 or 2 pattern or 5 or 6 or 7 pattern, depending upon that, we will consider that you will suffering from constipation predominant or diarrhea predominant. So that patient teach us that before diagnosing or before subclassifying a IBS patient, after diagnosing that is IBS patient, you should follow the Bristol stool scale to subclassify the patient, whether she is suffering from diarrhea or constipation, or a mixed variety or unclassified.
How can physicians and gastroenterologists collaborate better for early IBS diagnosis?
Regarding collaboration between physicians and gastroenterologists for early diagnosis, most of the IBS patients used to come to the physicians, and mostly the refractory type of IBS patient used to come to us. So during treating IBS patient, we should have collaboration with the physician, and first physician will face the patient and they will manage. And if they have this, if we follow single protocol, and that is the standard guideline, and there we should have some SOP to managing IBS, and that SOP should be followed by the physician as well as gastroenterologist. So which patient, the early diagnosis and the milder case will be treated by the physician, and the refractory cases will be treated by the gastroenterologist. So definitely collaboration is needed. Those patients who are refractory, those who have need some investigations in the form of any colonoscopy or in the form of any endoscopy or in the form of any rectal manometry or balloon expulsion test or colonic transit time, like this kind of patient, like those kind of who are not responding, who are little bit of refractory, those patients we need to treat, and those patients should be referred to the gastroenterologist. So for that reason, there should be a good collaboration with the physician as well as the gastroenterologist. The physician will first face the patient, they will manage the milder case, and the moderate to severe case, that will be managed by this gastroenterologist. Thank you.
Thank you, doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.